Good afternoon. Thank you to the European Society of Hypertension as well as the Journal of Hypertension for providing us this opportunity. We appreciate the opportunity to be here. We'll be presenting a case entitled "A Woman with Polycystic Kidney Disease, the Role of Precision Medicine in Hypertension Management." By way of introduction, we're presenting a case involving a polycystic kidney disease patient, and we were asked which one of us is a nephrologist, and the answer is neither. My name is Donald Clark III. I'm a cardiologist at the University of Mississippi Medical Center. My co-presenter and mentor is Daniel Jones, who by training is a general internist, but currently serves as the Sanderson Chair of Obesity and Metabolic Diseases and Nutrition at the University of Mississippi Medical Center as well. We have no relevant conflicts of interest to disclose. So our case, similar to the last case, is a 48-year-old woman that presents to hypertension clinic in 1996, so greater than 20 years ago. There are elements to this case which are interesting to the current era of lower blood pressure targets, so we felt this case would be interesting to discuss. This particular patient had a 1-year history of blood pressure elevations, intermittent systolic blood pressures ranging from the 130s to 140s millimeters of mercury. Her father died of complications related to chronic kidney disease in the setting of a diagnosis of polycystic kidney disease. The patient's medical history was otherwise unremarkable. On physical examination, the blood pressure was 146/92 millimeters of mercury seated. Heart rate was 74 beats per minute. Height was 5 foot 9 inches, weight 142 pounds for a body mass index of 21 kilograms per meter squared. The physical exam was normal, including a regular rhythm, normal pulses, no murmurs, no jugular venous distension, and no edema. Baseline laboratory data included a creatinine of 1.1 and a BUN of 18, which is an estimated GFR around 60. Electrolytes were normal. Urinalysis was unremarkable. No protein or red blood cells noted in the urine. Glucose and lipids were normal, including a low-density lipoprotein cholesterol of 64 milligrams per deciliter. Chest X-ray and ECG were normal. And a renal ultrasound was obtained for screening, given the patient's family history of polycystic kidney disease. You'll see a representative image of the renal ultrasound that was obtained, documenting numerous bilateral renal cysts, confirming the diagnosis of polycystic kidney disease in this patient. So I'll stop here for discussion and raise the questions of, among patients with autosomal dominant polycystic kidney disease and hypertension, what are specific considerations regarding antihypertensive agent, method of blood pressure monitoring, and blood pressure goal in these patients?
Okay, we don't have rush to the microphones. I think you can maybe continue. Yeah. You want to tell us the answers if they not
okay.
They not yet in the spirit.
Okay. All right. So again, our case was from greater than 20 years ago in 1996, and so comparing recommendations in 1996 by Cecil's Textbook of Medicine to current day recommendations, the modern Textbook of Medicine and up to date, in 1996 for patients with polycystic kidney disease and hypertension, office blood pressure measurement is recommended. In 2018, office blood pressure is recommended in addition to supplementing with home blood pressure measurements. Ambulatory blood pressure monitoring is recommended if there's a suspicion for white coat hypertension or masked hypertension, noncompliance, drug resistance, or hypotensive symptoms. In terms of agent used, ACE inhibitors are recommended as first-line antihypertensive regimens in 1996, as well as current day, and diuretics as second line. There's been some data in the interim regarding calcium channel blockers potentially promoting cyst formation in these patients. In terms of target blood pressures in these patients, in 1996, target blood pressure was less than 140/90 millimeters of mercury. Today, it's 130/80 millimeters of mercury, with consideration of more strict blood pressure goals of less than 110/75 millimeters of mercury for select patients, including young, healthy, and normal renal function.
Yes, please.
This target that you are citing here, less than 30, so 130/80 millimeters of mercury, is it the target for all the patients? Would you diagnose hypertension for specific population of polycystic kidney disease at 130/80, or would you diagnose it at 140/90 and target this blood pressure? because there's some discrepancies between the European and the American guidelines concerning the diagnosis.
So you point out there are differences of opinion here. I think, so I'll give my conflict here. I'm a co-author of the American guidelines, and so I support the 130/80 as both a diagnosis and as a goal therapy. But at the time this patient was treated, 140/90 was certainly the standard all around the world for both a diagnosis of hypertension and a goal blood pressure as well.
My second question would be, do you think that ACE inhibitors in patients who have no hypertension with polycystic kidney disease would have some benefit?
I don't think we know the answer to that question. Some nephrologists in the audience might weigh in on that. I don't know that we have evidence, but certainly I was treating this patient in 1996, and my inclination was that both the use of ACE inhibitors specifically and a lower blood pressure might give the patient a better chance for preservation of renal function over the long term. That was the primary goal of choosing that particular drug class, and it was the goal of choosing a blood pressure goal even below the 130/80.
Two remarks. One remark, in this patient to have a 24-hour blood pressure measurement done because there is no deepening is very often in the patient kidney disease, especially in patient polycystic kidney disease. No deep is very often. And second, there are a lot of data. We have also presented one poster yesterday in patient with polycystic kidney disease and EGR nephropathy. Progression is related to the blood pressure at night. So that is extremely important to identify this patient and trying to target blood pressure at night instead of his blood pressure.
Yes.
And second remark concerning the progression and polycystic kidney disease is smoking. If this patient was smoker or not? Because
not a smoker. Yeah.
Is no smoker.
Yeah, she was not a smoker.
Okay, so there's no problem because the smoking is an important risk factor for the progression and from disease growth as well.
Yeah, this patient was one of the patients that lived the healthiest lifestyle of any patient I treated during that period of time. And your other questions and comments are exactly on point on this case, as you'll see as the case unfolds. As was pointed out, the standard recommendation for blood pressure measurement of this kind of patient, of the patient with polycystic kidney disease at the time, was simply measuring off his blood pressure. Ambulatory blood pressure monitoring was just becoming available in our practice at this time. I will say that it occurred to me that it might be a good idea to do it, but as you may know, in the United States, ambulatory blood pressure monitoring is very expensive. It's a real deterrent to doing it unless there's a very specific reason for doing it. So it was not done at baseline on this patient.
Just a comment from a nephrologist perspective about ACE inhibitor and polycystic kidney disease. So the main data come from the HALT trial, and maybe you have a slide on that showing some benefit of using ACE inhibitor in patients with polycystic kidney disease with various targets. So I kind of work at the center, contributed quite a bit of patients with polycystic kidney disease, and with Dr. Torres from the Mayo Clinic, and then Dr. Schreier, there's main author on those HALT papers.
Yes, thank you for that comment. Certainly, in 1996, there was less focus on evidence-based treatment, and there was less evidence available about the utility of ACE inhibitors and renal function. So we'll go on with the case now.
Okay. Great.
Great points. In terms of blood pressure targets and data we have available to address these targets, and what the recommendations are currently based on, is largely from this trial by Schreier et al., published in New England Journal in 2014, was the HALT PKD randomized trial, in which they randomized patients with early autosomal dominant polycystic kidney disease to either standard blood pressure control, defined as less than 130/80 millimeters mercury, or strict blood pressure control, defined as less than 110/75 millimeters of mercury. And the primary outcome was change in total kidney volume over time. As we know, the natural history of patients with polycystic kidney disease is a progression in total kidney volume, which leads to progressive decline of renal function. And so results of this trial are demonstrated here in this graph. As you can see, the standard blood pressure arm had more progression in the total kidney volume over time as compared to the low blood pressure arm, and those findings were statistically significant. So summary of this trial was that strict blood pressure control in this patient population can reduce progression in total kidney volume. Other outcome shown here is change in estimated GFR over time, and there was no difference between the two blood pressure control arms in terms of that outcome. So back to our case. As Dr. Jones mentioned, a shared decision-making model was employed in which a target blood pressure of 120 to 130 compared to 140 was discussed in terms of the fact it may preserve renal function and reduce cardiovascular risk based on observational data that was available at that time. Lack of firm evidence and risk of hypotension were acknowledged and discussed as well, and together the patient and the clinician chose a target of 120 to 130 over 75 to 80 millimeters of mercury. This is a timeline of the case, as you can see here. And so what I'll do is I'll summarize the therapy that was implemented for this case in the following boxes. So based on the target goal that was set, lifestyle therapy and benazepril 10 milligrams daily were implemented. Subsequent to that, the patient remained above target goal with an office blood pressure of 132 over 84 and a home blood pressure average of 126 over 80. Therefore, the next subsequent implementations of medical therapy, benazepril was increased from 10 to 20, and hydrochlorothiazide 25 milligrams daily was started. Subsequent to that, the patient did achieve blood pressure control with an office blood pressure of 122 over 78 and a home blood pressure average of 118 over 72 without experiencing symptoms when changing from sitting to standing. After the patient achieved the set target blood pressure goal, 2 months followed in which the patient underwent an eye exam in which decreased visual fields were noted, with an intraocular pressure of 15 millimeters of mercury, which is within the normal limits, suggesting the diagnosis of normal tension glaucoma. So at this point, we have a patient who is at goal based on the target that was set and is now experiencing decreased visual fields, raising the concern that potentially hypotension could be contributing to these symptoms to some degree. Therefore, ambulatory blood pressure monitoring was considered for further diagnostic workup. So as far as the next discussion, I'd like to direct towards the topic of ambulatory blood pressure monitoring and raise the question of what are physiologic patterns specifically of nocturnal blood pressure and what conditions are associated with exaggerated nocturnal hypotension.
Okay.
Well, the question is it related to polycystic kidney disease or any situation? For any situation, if we have nocturnal hypertension, perhaps there are some probably increased vasodilatating factors that could be secreted, but there are no proof of that in terms of physiology and that could be related to PKD. Most of patients experience because of the position that is a recumbent position or supine position, the change would be for increase of blood pressure in situation. So, I mean, most of the elements, hormonal elements that allow hypertension are decrease of glucocorticoid secretion and the decrease of hormones that allow or increase of NO. So I don't see any elements that could explain without a hormonal that could be specific to polycystic kidney disease. I don't know anything that is specific to PKD.
So if I can add to this, I absolutely agree with you. And if anything, we teach students that this is a form of secondary hypertension with no dipping. So are you over-treating this patient?
So that is the important question, is whether the visual problems identified by the ophthalmologist could be related to our treatment of the patient. So let me pause here to say I've already acknowledged that I'm a co-author of the guidelines, the American guidelines that suggest 130 over 80 even for elderly patients.
And she's relatively young.
She's relatively young.
We're getting really worried.
Right.
We're getting worried.
You're right. So I'm presenting this case a lot in America to raise the concerns, just as we have to be concerned as we move toward tighter glucose control. We have to be concerned with hypoglycemia as a concern in managing those patients. We don't think as much about symptomatic hypotension, but as Trey will point out in a minute, there are some recognized clinical conditions that come from overtreating hypertension in some patients. These are rare patients, I think, but this case is presented as a thought-provoking process about how we should be careful about treatment of patients, trying to get them to very low goal blood pressures. And as you'll see the case unfold, in this particular case was relevant.
May I ask another question? In terms of sympathetic activity, do we know anything about her sympathetic activity, her heart rate? And secondly, when was she taking her medication, at night or in the morning?
She was taking the medications in the morning and not at night. Dr. Clark is going to show the ambulatory blood pressure monitoring results in a moment, but we didn't see any evidence of increased heart rate at night in this patient. We'll simply see. So we often use the term nocturnal non-dipping, and we perhaps will see some evidence of nocturnal overdipping in a patient.
Great. So we hear more story, right? Right. The story now continues.
So just show this as an example of a typical profile of 24-hour ambulatory blood pressure monitoring, where daytime blood pressure is represented here, nocturnal blood pressure here, and back to daytime. 140/90 being the measurements here. And as you can see, over the course of the day, you get blood pressure variability in both systolic and diastolic blood pressure. And then at nighttime, we get the typical nocturnal blood pressure dipping, and then get the typical morning blood pressure surge following that. These are patterns of nocturnal blood pressure, where normal dipping is defined as 10 to 20% decrease in blood pressure at night, and this represents most of the population. Non-dippers, defined as less than 10/5 millimeters of mercury decrease in blood pressure at night, but there are variable definitions for that in the literature, and this is associated with increased cardiovascular risk in multiple different cohorts. And then we have extreme dipping, which is defined as greater than 20% decrease in nocturnal blood pressure, which some studies have suggested may be evident in up to 30% of patients. Extreme dipping has been associated with multiple different adverse events, including silent cerebral infarction, silent myocardial ischemia, cognitive impairment, ischemic rest pain of the lower limbs, ischemic optic neuropathy, and normal tension glaucoma. Extreme dipping has been looked at in a meta-analysis including greater than 17,000 patients that underwent ambulatory blood pressure monitoring. These results were stratified by patients treated for hypertension and those untreated for hypertension. Among those untreated, a random effects model demonstrated a hazard ratio of 1.92 for cardiovascular disease. Among those treated, the hazard ratio was 0.72 and not statistically significant, suggesting that extreme dipping is harmful in untreated patients, but with no apparent additional risk in treated patients. Back to the case. As you recall, the patient was at target blood pressure and had an abnormal visual field exam. Patient underwent 24-hour ambulatory blood pressure monitoring, demonstrating a daytime average of 112/74, a nighttime average of 106/64, and a nighttime low of 88/56, which is greater than 20% and consistent with the extreme dipping pattern. Following these results, medications were adjusted. Benazepril was decreased from 20 to 10 milligrams daily, and repeat 24-hour ambulatory blood pressure monitoring was obtained, showing improvement in the nighttime low, as can be seen here, with a daytime of 124/82, a nighttime average of 112/72, and a nighttime low of 106/68. As follow-up, the eye exam normalized, and the office blood pressure maintained 125 to 135/75 to 80 millimeters of mercury. So as a note on nocturnal hypotension and normal tension glaucoma, there have been several studies demonstrating this association. The damage occurs despite normal intraocular pressure, and there have been several proposed mechanisms, including reduced perfusion of the optic nerve head, hemorrhage of the optic disc nerve fiber layer. So at this point...
Before you go any further, could I ask, from your reading about this complication, how common is it? Are these anecdotal cases, or has there been any broader look? How commonly does it occur?
In my reading, it largely remains anecdotal, and there's not been large case studies describing prevalence rates in a larger population.
I'm just judging from my own experience. I've never seen it, and I've seen quite a few people with too low blood pressures, right?
Yeah, so this may be an appropriate time. So I will confess that when I received the note from the ophthalmologist, I questioned this because I'd never heard of it. And of course, I was a graduate from medical.
Join the club. Join the club.
So I presume the ophthalmologist must be wrong, that, surely this wouldn't be a real thing if I'd not heard of it before. So let me ask the audience, if you've seen a patient or have you recognized a patient in your practice who had, from nocturnal hypotension, had low pressure or normal pressure glaucoma? Would you? Okay. All right. How about, are you aware that this exists? Before hearing the presentation today, were you aware that this existed? Okay. There's some who are aware. Yeah. So what my review of the literature is, the ophthalmology literature is filled with anecdotal cases. There probably, I found 30 or 40 articles about this problem in the ophthalmology literature. Outside of the ophthalmology literature, I only found 2 or 3 references to this, and very little in the hypertension cardiovascular literature. One of the reasons I chose this case to be presented at this conference was because it would be published in Hypertension, and I thought that it might be useful for more of us to be aware that this could occur in patients, again, particularly because I and others are so interested in achieving lower blood pressure in more patients. I think we have to be aware that there are things that we need to be aware of.
That's great. There are some questions, please.
I have one comment and one question. One comment regarding your question. I've seen patients with optic nerve, ischemic optic nerve, because of extreme low blood pressure and at night. But there was a very particular patient who was on dialysis with no kidneys. She was anephric, so it really doesn't apply. My question for Dr. Clark, on the slide, when you define the extreme dipping, you showed the lowest blood pressure at night, which is quite low, but then you also showed the average. So just to clarify, is you defining the dipping based on a 20% decrease, not on the average, or because the average didn't seem to be more than 20% difference than the average daytime? I mean, comparing the average daytime versus the nighttime.
I don't remember in that particular study that identified that whether they used average or the lowest, but I think in terms of clinical application, my concern would be the lowest blood pressure. This patient's average blood pressure at night was not that low. It was the most severe drops in the blood pressure that were the problem.
Yeah, and that's a good point. That's a tough one because these are not very common cases. I mean, blood pressure varies during the day, right, from higher reading to low reading. So we look at the average, but then the night is this different, and how do we approach that? So
when I attend these conferences and visit the exhibit hall, one of the things I do is to every company that makes a blood pressure measurement device, I beg them to develop a comfortable nighttime blood pressure monitor that we can use on patients. There's not an easy way to determine nighttime blood pressure now. Omron made a monitor that measured blood pressure 3 times at night and sold it in Japan for a few years, but they've discontinued the sale of it. There's not one on the market now that aware of, other than using the ambulatory blood pressure monitor, which is a very cumbersome way, expensive way to do it. And I think likely, especially elderly patients, as we go for lower goals, if we have a technology to do it, we're going to want to monitor a lot more patients' nocturnal blood pressure.
Okay, go ahead.
To return back to the mechanism, perhaps this patient has a hyperactivity of her sympathetic nervous system that allows us to be high in blood pressure during the day and low during the night, and this perhaps could explain in part this phenomenon. The other thing is how to use the tools to decrease this risk. I think that short-acting antihypertensive drugs that could be more influent during the day and less during the night would be very good for this patient. I mean, we have some calcium channel blockers like nitrodipine, Nidrel is a short-acting. Some ACE inhibitors are also short-acting, like captopril, etc. That it could be used during the day and respect blood pressure during the night. And perhaps using a continuous blood pressure monitoring, like with new technologies, heart watch, or ABPM could be better in this kind of patient to detect hypertension and to prevent such complications.
Yeah. So thank you for all of that. So there are not enough of these patients to do a clinical trial to answer the first question, whether short-acting drugs might prevent this problem. It makes sense to use a short-acting drug rather than a long-acting drug in these patients. The opposite of this, trials that look at trying to use nighttime dosing and longer-acting drugs to treat non-dipping so far have not demonstrated benefit in the chronological adjustment of medications or the duration of medications, haven't made a difference in outcomes of non-dippers. So it's something that needs to be explored. I suspect that as we move toward more and more patients on lower blood pressure goals, that we'll see more of these patients, and eventually probably we'll have some clinical trial data that will be meaningful in this area.
Please go ahead.
Just very short, with backside of hindsight, don't know how to say that. Don't you think that adding hydrochlorothiazide 25 milligrams was a bit much? I don't know, maybe 12.5 milligrams are not available in the United States?
Yeah, a very good observation. And by 2019 standards, absolutely, that's a huge dose of hydrochlorothiazide. By 1996 standards, that was the beginning dose recommended in most of the blood pressure guidelines at the time.
And why did you lower the ACE inhibitor and not the hydrochlorothiazide for the same reasons?
So probably prejudice of my practice. So sodium intake is very high in the area where I practice medicine, and so it's harder because of my bias about that. It's harder to stop the diuretic than an ACE inhibitor. The hydrochlorothiazide is short-acting thiazide diuretics. His 4-hour lifetime, I don't think that it is responsible. Yeah.
I think that the longer-acting drug is the ACE inhibitor more than sure. That's why today we say use clotridone or indapamide, then hydrochlorothiazide for better control. Donc, for me, it's not hydrochlorothiazide that could explain this phenomenon.
Yes, so this was in 1996, and I don't remember for sure, but I hope my thinking was as clear as yours about which drug to manipulate.
Okay, last comment, yeah?
I have a general question. Do you perform for all patients with ADPKD in the USA tomography of head because of, let's say, suspected aneurysm or not? Do you perform of CT, head CT, cranial CT? For all these patients with ADPKD, because we know that very often this lowering of blood pressure is because of this complication, eruption of aneurysm in the head. So do you perform CT scan for all the patients with ADPKD or not?
All patients with what?
With polycystic kidney disease.
Polycystic kidney disease.
Adult type. So
it's not part of standard recommendations.
It's not.
It's
so
not.
you don't?
No.
Okay.
Okay, could we hear more of the story? The story continues.
Well, in terms of the discussion, as we carry on in the era of lower blood pressure targets, we're interested in discussing how do we apply the principles of precision medicine to prevent unintended consequences of hypotension, as Dr. Jones has mentioned, while also maximizing lowering the risk of cardiovascular disease. And can ambulatory blood pressure monitoring be better, more affordable, convenient, and available? And so in terms of 24-hour ambulatory blood pressure monitoring, we would suggest that this can be viewed as a precision medicine tool in order to better individualize therapy for specific patients. At least in the US, there needs to be broader utilization, and this can probably be, uptake can be greater with persuasion of reimbursement by payers, continued guideline efforts. The European Society of Hypertension has provided much support in terms of ambulatory blood pressure monitoring, and integrate ambulatory blood pressure monitoring into performance measures. But more research is needed, including how ambulatory blood pressure monitoring might impact antihypertensive therapy in the era of lower targets, as well as validate the associations that we previously told you about in terms of extreme nighttime dipping and the adverse associations with that. So as mentioned earlier, do we have new technologies that might be able to be better utilized? Is there a cuffless future in which new blood pressure technologies are implemented? There are new technologies currently in development, including tools that use things like optical sensing of changes in light absorption with each heartbeat, radar, and wearable sensors. All of these largely remain in investigational phases, but as technology continues to develop, hopefully we'll have further research to validate these new methods. So in conclusion, nocturnal hypotension may be seen more frequently with lower blood pressure targets. Extreme nocturnal blood pressure dipping has been associated with certain conditions, including normal tension glaucoma. Ambulatory blood pressure monitoring is a valuable precision medicine tool, and broader utilization of ambulatory blood pressure monitoring is needed, and improved technology is also needed to implement better measurement strategies. So we'd love to open the floor to further discussion and final thoughts.
This is great, and lots of points here for discussion. Could I ask, ambulatory blood pressure monitoring in Europe and European guidelines, as you said, is sort of, we won that war, and it looks like you've already almost won it. My information from American Heart Association is that the battle is at least won or almost.
Right.
Can we really say that something that should be applied for everybody? We would like ambulatory blood pressure monitoring at least once on every patient. Is that really precision medicine tool to be? It sounds nice, but is it real?
Yes, I use the term in a provocative way, purposefully,
Okay.
Certainly, we are getting closer to winning the battle in the U.S.
Yeah.
But still, it's underutilized by clinicians. And as this is published and read by an audience all around the world, I hope the American audience will look at this and see this as a need for standard approach, pre-treatment and post-treatment to use ambulatory blood pressure monitoring. And I hope that the engineers, the biomedical engineers will look at this, and the companies who make blood pressure devices will look at this, and we'll see that there is a large market for 24-hour monitoring of blood pressure that can be done in better ways than is available now. My hope is that there will be a patch sensor that can be worn around the clock, and that
Like for glucose.
like for glucose.
Yeah.
Like for glucose. And again, if our goal is 140/90, it's not so important. But if our goal, especially for elderly patients, is to be 130/80, I think this should become a standard approach to management of patients, to continuously monitor the blood pressure, including it at night.
Okay. Any other points from the audience? Rhian?
Can I ask a question? Thank you so much for sharing with us your thoughts and the information about the ambulatory blood pressure monitoring, particularly with respect to non-dipping and this sort of very hypotensive effect. In the research that you did relating to this, what were your thoughts about reverse dipping? In other words, when nocturnal blood pressure is higher than daytime blood pressure, because that also provides enormous challenges from a therapeutic point of view, and also are the outcomes worse in those patients compared to non-dippers?
Yes, the outcomes are worse in non-dippers, and so some of the evidence for the risk associated with non-dipping comes from the Jackson Heart Study, which is in our home institution, and especially in some ethnic groups. African Americans have a much higher prevalence of non-dipping. The Jackson Heart Study has a cohort of patients in the 55 to 75 year age range, and about 25% of those patients have non-dipping, and the Jackson Heart Study has enough follow-up data to show that it's very predictive that there is a higher cardiovascular risk for patients with non-dipping than patients who have ordinary dipping at night.
And for reverse dipping, where blood pressure is higher at night than daytime, is it even worse than non-dipping?
It is. The higher the blood pressure is at night, the more nocturnal blood pressure, especially related to the daytime blood pressure, the higher the cardiovascular risk. All right.
Great, please.
I have a question for you. First, as a nephrologist based in the US, I totally agree with you that ambulatory blood pressure is very underutilized, and we really need to push that further. To play devil's advocate is how about information overload in the era of electronic medical record, where patients can reach us very quickly, have question, when we have blood pressure monitor ongoing 24/7 for weeks and weeks, and we have couple of patients are always more obsessive, and they will contact you anytime. Oh, my blood pressure, and we know it kind of varies. How are we going to handle all this information? And this patient may be just 1% of the population, but if you multiply this and we open kind of Pandora's box, so we're going to have the information overload. How can we handle this? Are we having nursing staff doing the screening for us and so forth?
So the cardiologists are ahead of the rest of us on this. They handle arrhythmias. They've gone from the patient calling you when there was a problem to monitoring, having a nurse watching a monitor, to some type of artificial intelligence now that will alert when there are problems, and now they have devices that they implant in patients that go ahead and apply the treatment before a physician is involved in decision making, or at least involved for ahead of time. I think we'll get to that in blood pressure management. I think we'll have monitoring that will be relayed to a system that will have artificial intelligence that will then alert someone to make a decision about things. So earlier today there was a presentation on telemonitoring of following patients with chronic blood pressure, and looked at a number of interventions, including physician intervention, pharmacist intervention, and patient self-administration intervention. And someone mentioned glucose monitoring. Certainly, the glucose monitors and the associated insulin doses are standard therapy now. And I think we'll get to that kind of thing in blood pressure management eventually as well.
I want to ask one question. You see, I'm coming from a region, the Middle East, where we do have a lot of siesta, nap, and we have noticed quite a significant fall in blood pressure. Even though during the day it is okay, but when they take the siesta, then the blood pressure comes way down. What is your experience, and what shall we do, you see, with these patients are well-controlled clinical blood pressure?
I have no experience with siesta, personal or with patients. Yes, we need to understand that. We need studies done in cultures where siesta is a typical part of the culture. We need to understand what happens to the blood pressure during the siesta, what happens in the early evening hours, and then what happens to it when at bedtime and beyond. Yeah. So one of the challenges that in interpreting the 24-hour blood pressure cycle is the chopping it up into segments. And so often you see papers reported of daytime and nighttime blood pressure. More and more papers are pointing to awake blood pressure and asleep blood pressure as something that's more accurate. And I think we'll need to see the same kind of data from cultures where siesta is a part of the culture.
What I recommend, you see, that is very important, is that in the ambulatory blood pressure reporting, that it is not, you see, people do not pay attention to the fact that these patients may have a nap. And we ask our patient to tell us whether they are having a nap or sleeping. And this is something, unfortunately, you do, and many of the ambulatory, even in our country, they don't take care of this.
So one of the limitations of this technology now is that we ask the patients to report when they're upright and supine, when they're awake, and when they're asleep. And certainly that would be an easy thing to include in technology that would give us the position of the patient and would give us whether they were awake or asleep, and certainly would add much to the understanding of posture and sleep and awakeness in blood pressure management. Certainly
Yes.
would.
Absolutely, Dan. We've been doing this for about 20 years in experimental animals. Why can't we do the same in human patients?
Right.
The telemetry monitoring that's been used by our community for years and is recommended for blood pressure measurements includes activity. You can't do it without it. That is obligation. So you're absolutely right. We have 2 more comments.
Just a very quick question. Maybe I missed something in your presentation, but the patient had orthostatic hypotension. And the other thing that came up with my mind was if she had postprandial hypotension.
Right. So the answer to both is no. She did not have orthostasis, and she did not have postprandial hypotension. The only episodes of hypotension she had was when she was asleep at night, right? So she was doing home blood pressure monitoring, and I had asked her to take both erect and supine and to do it in the right time sequence to recognize that, and also I'd ask her to monitor her blood pressure after meals as well. All of that was perfectly okay. Good questions.
Okay.
I thought about those too.
I would like to make a comment about the need for sophisticated technology to acquire simple data. Mm-hmm. We have been doing ambulatory monitoring for, I will dare and say, decades.
Yep.
And had described effect of daytime napping and nocturnal urination on ambulatory monitoring cycle. And yes, you can do it with technology, but one can also ask the patient questions, and sometimes you get helpful answers.
Thank you. Yeah, thank you for that. So before I sit down, I want to make one more point about this patient that I didn't want to confuse the presentation with this. The primary purpose of trying to control the blood pressure very tightly was to preserve renal function. So yeah. This patient now is 24 years roughly out from her diagnosis of polycystic kidney disease and the decision to manage her blood pressure more aggressively. So she also developed, over that period of time, scleroderma, and also developed hypercholesterolemia. And so this patient has had a mild stroke and has had 3 stents placed for coronary artery disease, but she still has normal renal function. This is not a clinical trial, but it gives me hope. Gives me hope to think that tight control of blood pressure may help preserve renal function in some patients long term. So, Madam Chairman, I thank you for the extra minute to give that propaganda.
Thank you very much. So I think we had 2 fantastic cases. Thank you very much.